Good morning, everybody. So we'll be discussing another special population which is often not discussed, and we often are very reluctant in uh, deciding what to do, which is the LGBT population or the sexual minority, and how to provide care in those population if they encounter with substance use. I often see patients with this community coming in the sexual and marital clinic because of various mental health problems, sexual problem, and some of them have also substance use. So I'll be discussing about those. So this presentation is based on the available literature, and I don't intend to hurt the sentiments of this special group of population if I discuss some issues, and I declare I have no conflict of interest. So the current agenda is why to focus on this special population, whether they are at high risk of addiction, how does it impact the community, and what are the special about the management aspect as well with any other patient coming for treatment with substance use disorder. So I think that everybody must be knowing about the full form of these letters, but now currently the term is not limited to only LGBT. The various have been added up like LGBTQ, then Q, which is questioning, then plus suggests that there are intersex, ally, asexual, and last is pansexual. So the terminologies are increasing as the sexual minority is also gradually increasing. They are becoming more broader concept. Now, why to focus on this population? How grave is the situation? The data which is available, there are some of the statistics which are available from the various surveys which have been conducted in developed countries, mostly from USA, Canada, Europe, and Australia. And they suggest that there is a clear link between those who identify as LGBTQ and the increased risk of substance misuse. The main data is from the SAMHSA, which is the latest one is from 2021-2022 survey, and they have specifically focused on this LGBT population also, what is the trend in their substance use, and also from the National Drug Strategy Household Survey, which the latest one is 2023 from the Australia, and I will be also discussing one preliminary data from our country also. So based on this data of the SAMHSA, they have clearly demonstrated that, as if you can see from the figure, the cigarette smoking as compared to the straight males and female, those with females, lesbian, bisexual, and gay and bisexual, the cigarette smoking rates are quite higher. Similar with any alcohol use, binge alcohol use or heavy alcohol use, you can see the figures, they're quite high as compared to the heterosexual peers. Similarly, with regard to the illicit drug use, they are very, very high with compared to marijuana use and any other drug use other than marijuana. This is very high in the LGBT population as compared to their heterosexual peers. And if we discuss about the substance use disorder, because if the use is high, obviously the substance use disorder is also high in this group of population with regard to the statistics from SAMHSA. Now, when we see the Australian data, that is the National Drug Strategy Household data, we see that over the years from 2010 to 2022-23, the percentage of people smoking cigarettes have gone down in both the LGBT and the heterosexual people, but the current e-cigarette use has skyrocketed in this group of LGBT. Similarly, risky alcohol consumption and illicit drug use is quite more in this group of population. If we see what are the illicit drug use this population use, the most common is the cannabis, followed by cocaine, inhalants, ecstasy, and hallucinogens, which are very high as compared to the heterosexual population. And it has been shown that transgender students are more likely, around 2.5 times more likely to use other drugs like methamphetamines and cocaine with regard to the cisgender peers. Now coming to the Indian data, this is preliminary data. This was a multicentric study which was conducted across 4 centers AIMS Bhubaneswar, KGMU Lucknow, and Lokmanya Tilak Hospital Mumbai, and JIPMER Pondicherry. The investigators are from the 4 institutes, and they have collected sample from about 1001, which include 35 lesbian, 289 gay population, 150 bisexual, and 500 transgender. They have looked into several aspects of their with regard to the mental health issues, and substance use is one of the component. So with regard to the substance use data, they have also shown that it is the same data as compared to the USA and Australia. That is, tobacco is highest, followed by alcohol, cannabis, and other groups are very low in this population. So key points from this epidemiological data is that there is high rates of substance use in this community, more in the youth population, and there can be more of underreporting data. These rates can be very high because they reach to the treatment center very less, and there is limited data from the developing countries. Now, why this population is at high risk for addiction as compared to the general population? There are various factors, so I'll be discussing one by one. First is that what they have analyzed from the data who are coming from the various qualitative data, also from the quantitative data, is that most of this population, they complain of bullying or harassment, which is quite common, and it is seen that 8 to 10% of the students have been verbally abused, or 4 to 10 report of physically harassed, and having a history of bullying or harassment increases the rates of substance use. So the LGBTQ students who have been victimized at school, they report higher rates of drug abuse, and they have linked this bullying to be related to emotional distress, somatic complaints, anxiety, depression, and loneliness, which paved the way for this substance use in this group. Now, another issue is of family conflict and rejection. As you know that this group of population, they often face family rejection because of the heteronormative ideologies in the families, and which becomes an important source of distress in this community, and facing stigma from the home itself and the family, significant family conflict, they significantly lead to physical and mental health concern, and they engage in risky behavior and substance use. And studies have shown there is a family acceptance process project which has been going on since many years in United States, mostly in California and San Francisco, and they have literally shown that those families which accept the LGBT youth as LGBT identity, there is more acceptance leads to lesser substance use, and if there is more family rejection, there are more serious health concerns as regard to the depression, suicidal thoughts, suicidal attempts, and illegal drug use. And as the levels of the family rejection increases, this mental health and the substance use problems also increase in this group of students or young people. Next, coming to the point is the minority stress. As you know that there is a minority stress hypothesis, and which is very clear in this group of population because they perceive rejected from the families, harassed from their peers, and demeaned in the media. So direct harassment or indirect harassment could be an obvious effect that they go for substance use to alleviate their anxiety, loneliness, and around 92% of LGBT surveys this report that these students or these youth, they hear negative messages about being LGBTQ population, and they some or other one, even if they are supportive, even if their friends are supportive, but most of them report that they have some level of minority stress. So this minority stress can be discussed in the form of distal stress factors, like they have gender related discrimination, they face rejection, they face victimized, and proximal stress factor that internalized homophobia or transphobia within themselves, negative expectation from treatment, hiding themselves to become an identity. So these factors lead to various negative outcome in the form of mental and physical, but if they have good resilience factors like the community connectedness and acceptance, then these outcomes can be changed. So what happens is that having a minority status leads to significant stigma, which can be external or internal, leads to bias, prejudice, discrimination, lack of acceptance, which leads to minority stress, because of which they face low self-esteem, anxiety, depression, which leads to substance use or various other disadvantages. This is the minority stress hypothesis, which is very well described in this population. Another factor is childhood abuse, which it has been seen that childhood abuse is a significant risk factor for substance use, and that hold good even for this population, because those children who have been targeted for physical and sexual abuse have higher rates of substance use. And recent findings have been mixed. They have shown that those bisexual and lesbian, they have more sexual abuse and they have been linked with greater substance use as compared to the heterosexual peers. Now, why they do go into this addiction, whether it is for survival or it is for pleasure seeking. So there are two views, because there are various surveys or various analyses have been done who have interviewed this subgroup of population, and they have found why they take these various substances. So there are various qualitative interviews. Out of that, I am taking some of the experts. They say that one person with alcohol use disorder, he says that I use alcohol in an attempt to briefly forget the self-consciousness that I feel as a part of this community. It loosens me up a bit, so I am not worried about things like my appearance or what other people think of me. Another individual says that substances make it easier to forget the LGBT teens' differences. They use them to feel more normal. So there are various, from this we derive that they take it to self-soothe or self-regulate, to as a way to numb or treat their hyperarousal symptoms of depression, loneliness, obsessive thinking, or impulsivity, in a way, in the service of walling off the traumatic intrusive memories, as a way to combat helplessness and to also to feel safer in the world. So this gives rise this circle of trauma and substance use in this population, what because of the stress due to prejudice or discrimination, and they have been, it is a new normal that they culturally accept that we have to take heavy dose of substances to become normal in this society, and because of the various discrimination further leads to the substance use disorders. Another one is the peer influence. Peer influence is also there in all the substance related issues, because most of this population, they seek support from their own community, because they are the more crucial source of support. But if those community or these teens, they also may be having drugs or alcohol, and if they meet the older crowd or they visit the various club cultures where this substance use is more common, they gradually indulge in the substance use behaviors. Another one important concept is that of the chem sex or the meth sex connection, which is oftenly discussed with the males having sex with male or the MSM population, because they frequently use this chem sex, which is sexual activity under the influence of drugs. Three most common drugs are mostly used as the methamphetamine, which is commonly called as crystal meth, and mephedrone or mio, and GHB and GBL, the gamma hydroxybutyrate. So these drugs have been used in connection with the sexual activity, because when they take these drugs, they feel less inhibited, they feel more sexual, this prolongs the sexual activity in delaying the orgasm, they have more intense orgasm, and they usually combine with other drugs. Because of this, they also indulge in a repetitive sexual activity or compulsive sexual behavior, and they further leads to more addictive behaviors. So some of the qualitative interviews of those MSM who have been taking methamphetamine have reported that they feel great. I feel completely without reservation, without inhibited. But I was just completely liberated. I was very, very sexually confident. So this leads them, they go into deeper and deeper into the addiction. So from this part, we know that older age and female gender, they do not appear to be robust protective factors in the LGBT communities. Alcohol use appears to be a greater problem than drug use for lesbian and bisexual women, whereas drug use is more common in gay bisexual population. Bisexuality is an additional risk factor, and substance use appears to be impacted by the club culture, sexual minority stress, and HIV status. Now, how it affects this community? Is it something different? Yes, because it has been linked with the mental health disorder very closely. There are various surveys which have shown that 2 in 5 LGBT populations struggle with serious mental health issues, and they are often associated with substance use disorder as a cause, effect, or co-occurring disorder, and comorbid mental illness and substance use disorder quite higher in this population. And this survey done by the National Alliance on Mental Illness, which is NGO, they report that LGBT individuals are nearly 3 times more likely than heterosexual to experience in mental health problem. And if this condition exists before drug misuse, then it can lead to further exacerbation of the problem like depression, anxiety, PTSD, or body image related disturbance and eating disorder. They have been more commonly researched in Western world, less common in our Indian population, because the Indian data which has been reviewed in this study from 2009 to 2019, which have summarized all the surveys done in this special group of population, they find that most of the subjects, the report of depression, alcohol use, most and suicidal ideation, moderate to severe depression, hazardous drinking. So these are also common in our part of the world. Now SAMHSA, which is the most important authority in USA, they have shown that one of the biggest risk factor for suicide in this community is the substance abuse. They have found several studies, and there is a project which is going on till date from 1998, and that is the Trevor project, which is to improve the outcome in LGBTQ population, mostly to prevent the suicidal attempt or prevent the suicide. So they have found that there is a greater risk of suicide in this population, including those who do not misuse the drugs and drugs that heighten the risk for suicidal activity. So this is the latest report which they have published in 2022, and they have found that prescription drug misuse was responsible for nearly increasing the suicide risk by 3 times as compared to alcohol and marijuana, which are also quite high. They also increase the rate of suicide attempt, but if the subject is on prescription drug abuse, it increases the further risk. So we need to access that this pattern of drug use in subject who identify with LGBT. So another impact is that if the subject is both LGBT and using substance, there is high risk of homelessness. They felt they have to reject. There are more chances that the families reject them, and this opens the door for further dangers, like they can be leading into unsafe sexual practices, HIV risk, suicidal tendencies, mental disorder. So homelessness is another one which affect this community at large, because there are various studies which have shown that the degree of homelessness in LGBT population is quite high as compared to the general population, and those who are homeless, they tend to have more suicidal ideation and more suicidal attempts. There is also, as you know, that there is increased risk of HIV and in this population because of the different degree of sexual activity. But if the subject is also on substance use, those rates are quite increased because of the decreased inhibition and risky behavior, which further contribute to transmission of HIV. Now coming to the management aspects, which is special. What is special in aspects in treating substance use disorders in this population? Now we know that there are various therapies or intervention which have been found to be effective in treating substance use disorders in this population. In particular, as we know that there are various strategies which we use in general population, like motivational interviewing, social support therapy, contingency management, cognitive behavior therapy, and they have been found that if they are tailor-made for this population, they have been found to be quite effective. So we need to choose what approach we need to do for this special group of population. But there is a wide treatment gap, because studies have shown that only 15% of this population, they come for treatment, and there is a wide gap, that is around 85% treatment gap even in the developed countries like USA, Canada and Australia. And there are greater unmet needs which have been reported by this population as compared to the heterosexual people. Like as you can see from the figures from the latest data, that those patients who identify as homosexual or bisexual, they have more unmet needs, and the treatment gap is quite high even in the developed countries. So why there is the treatment gap? The studies have reported that they feel discriminated by the healthcare provider, which is a burning issue, or those who are working with this population, that they find that this patient, they prefer to self-medicate or they have find difficulty in accessing private care because they face discrimination due to social stigma. There is also and physician homophobia, which can be deterrent for this patient to seek health care based on the traditional gender stereotypes. And it has been seen that the sexual minority women, they avoid accessing mental health care because of the stigma of mental illness and previous past negative experiences. So this is the data from the USA and Europe. They have found that 56% of this community, they don't access care just because of they feel discriminated by their healthcare providers. So the LGBTQ individual, they face two types of stigma, that is anticipated and expected stigma, that is they expect that they will be discriminated by their healthcare providers, and also by the structural stigma, that is they find the atmosphere to be unfriendly when they visit the healthcare professionals, so they prefer to continue with the substance use to cope up with the distress. And it has been seen that those who come for the treatment, and if they feel harassed because of the discriminatory attitude, there is more poorer outcomes. So what can we do? How to combat with this inequality? So there is the concept of LGBTQ friendly treatment program, which is being more and more propagated in the Western countries, because they have now developed substance use and mental health facilities offering special care for the LGBT client. There have been recommendations which have been postulated for gender affirming substance use disorder treatment. More LGBTQ friendly rehab programs are being designed, and we need to create more awareness in the mental health professional to destigmatize LGBTQ. So these rehab programs, which are mostly developed in the USA and Australia, they have been designed to cater specific needs to the LGBTQ community. They provide comprehensive support who are dealing with addiction and mental health problem. They are with the routine treatment option, just like we do with any other client, like detoxification, behavior therapy, and outpatient service. But they differ that they provide a safe space with staff trained to understand the specific stressors and the challenges faced in a non-judgmental environment, promoting acceptance and healing, which has been thought that it will bring out greater recovery chances. So they have recommended some of the recommendation how to create a more LGBTQ friendly atmosphere in the de-addiction centers or the clinic, so that they come for the treatment. So these are the recommendations, that we have to create a more welcoming environment by displaying that we are more LGBT friendly, create, disseminate, enforce non-discrimination policies, recruit and train LGBTQ staff providers. We have to have a gender neutral restroom and provide ongoing training and capacity building, and we have to develop a culture of openness to discuss LGBTQ issues in those patients who are also coming with substance use disorders. So these are some of the recommendations. And what we have to adopt in the screening and evaluation procedures is that we have to develop a non-stigmatizing opportunity. We have to provide opportunity to the clients to self-identify their sexual orientation. We can give them the pro forma and ask them, how do you identify yourself, rather than asking them the questions. We have to ask the clients about their gender pronouns they prefer to use. We can also ask about relationship status rather than marital status. And if the data collection process, we have to frame in such a way that it does not further stigmatize them. We have to express empathy while we're interviewing with them with non-judgmental attitude. Be prepared to follow the client's lead about how much they want to discuss about their identity in the context of the treatment. If they don't want to discuss, then we don't want to pressurize them to discuss, because they have not come for that purpose. We have to empathize with confidentiality, and we have to use gender neutral language. And if we make any mistake, if we pronounce the wrong gender, we have to politely apologize and correct for the behavior. If we follow this behavior, only then we can retain them in the treatment network. So along with that, the recent treatment research on this LGBT population with substance use disorder, the available evidence suggests that those abusers, they require specialist treatment protocols, but this treatment protocols is mostly related to how the behavior change is there in the mental health professional or the those who are dealing with this population. They don't require any specialist treatment protocols for treating with alcohol use or opioid use. There is no such treatment protocol. Only is that we need to have an LGB culture and LGB specific patterns of substance use. We need to know and how to address them in a culturally competent care. Also, we should not forget the family. We need to also involve the family. There are various family-based intervention. We have to do some family intervention, so that, because there is much evidence that if the family is supportive and accepting, then there is quite effectiveness in the addiction treatment. And this involves recognizing the unique experiences and challenges faced by this individual, and they provide quite a good support so that they heal and recover. So summarizing whatever I have discussed, that there are high levels of substance use severity and high rates as compared to the heterosexual individual. They experience more substance use treatment barriers. Stigma and discrimination is more, and there are higher rates of mental health issues, which further negatively impact their ability to successfully quit substance use. There is a need to create more LGBTQ friendly environment in de-addiction clinics, and we need to tailor-make these protocols to approach to improve the treatment outcome in this special population, which we should not forget. Thank you.
Thank you, sir, for providing us the detailed overview of an important topic. This group of population, as we know, is more susceptible, as the stigma because of substance use and LGBTQ itself act as a double hit for the mental health morbidity. So it is a very important topic. And now for both the talks by Dr. Abhishek and Dr. Swapnajeet, we open the for any discussion and questions.
Good afternoon, everyone. I am Dr. Ribhav from GMCH Psychiatry. My question is from Dr. Ghosh. Sir, I have a two-part question. First is that why are some substances more criminalized than the others? And the second part is that there is a common government policy of continuously raising the taxes on less inhibited substances. But does that just make our economy more dependent on their consumption, which makes it more difficult to plan a prohibition of these substances, such as tobacco or alcohol?
Thank you very much for both the questions. Both are, it's not a very easy question to answer. So I guess, yeah, I'm audible. You see, the first question regarding why one substance is more criminalized than the others, I guess you are pointing, suggesting something like alcohol, tobacco, versus sir, right? So the answer is complicated there. It's more about societal acceptance rather than actual level of harm. There was this famous study which was published in the Lancet in 2007 by David Nutt and colleagues. They have tried and classify substances based on the amount of harm they produce to the individual level, and the amount of social harm. And finally, what they observed is that the amount of social harm and individual harm is more for alcohol and tobacco, understandably so, because more people consume that than cannabis, for that matter. But there are certain substances like heroin and methamphetamine who had individual level harms are more because of overdose risks and all. But from there, we could understand that the drug use policy is mostly driven not by the public health, but mostly by the criminal justice system. And the criminal justice system is mostly driven by the baggage of our own understanding and attitude towards people who use drugs and alcohol. So yeah, it's not that the kind of criteria that not used is known as multi-dimensional decision criteria. It is kind of a complicated criteria. People have criticized the criteria by which we measured, but there is no other better measure. So when you criticize something, there should be a better thing available, but nobody could develop something as good as the multi-dimensional decision criteria, which is developed by the Nuts group. So that's the kind of a longish answer to your first question. The second one that you asked, raising taxes, whether it helps, it does. It does. Means there is no doubt about that. WHO has been saying it for the tobacco since 2003, and for the alcohol now recently. The alcohol gap action program, yeah, raising taxes is one of the measures, one of the important, very important public health measures to reduce people from initiating alcohol and initiating tobacco use, but also to some extent to continue tobacco. Now, there are people who would say that there is a concept of price elasticity, and whether we don't know which group it's more affected, there's a kind of nuanced answer is required for that. And I would love to discuss you over a cup of coffee the nuanced part of it. The evidence-based part of it is it works.
Any other questions?
Good morning. I am Dr. Abhinav, Assistant Professor, GMCH. The question is for Dr. Swapnajeet. It's more of a very specific domain that I want insight into. So we do have patients who are in the process of transitioning their gender identity, and they do have gender dysphoria. Now the gender dysphoria for them, as in your presentation, is something which is leading to that distress, which is leading to the substance use. So now what should be our approach? Should we target the substance abuse first before working upon the transitioning process, or do we target the transitioning process first and then we assume that the substance use is going to go down by itself?
I think we have to focus on what they are going through. The process of coming out first to internal, it is internalized. That is, it's more difficult. It is more distressing. The second is that the most of this negative expectation from their family, acceptance from the peers, and the degree of stigma and discrimination what they are facing and what they feel that they will face if they come out, that is the most significant distress. So gender affirming care first focus on reducing this dysphoria, and it is seen that if they come out in a very good way and the family accept, obviously the other mental health issues and the substance use, they go down. That is quite seen.
Any other question, please?
I think one more question. Dr. Fitness.
Dr. Abhishek, how often does the fear that for a youngster in Punjab or the working area where we work around, that I will be caught and when I start using drug or I am in early process of using the drugs, deters a person from seeking help for drug treatment? Is there a data or whatever experience do you have? Kindly share it.
Yeah, that's if you ask about data, we do not have data for that because we didn't ask people whether the reason for not coming to the treatment, but the treatment gaps do exist. We understand there are 85% people who do not seek treatment, although this is not a state-wise data, it's a national level data. So the possible reason why people do not seek treatment, one of the reasons that is postulated is that people fear of being caught by the police. I would share a few instances which had actually happened, that had happened during the COVID times, when people were asked to stay back and people could actually move out of house during for treatment or emergency purposes. Now, OAMT is emergency treatment, and for that people should be, people are actually could actually travel from their places to the treatment facilities, but we have people telling us, patients telling us that they don't want to show their addiction treatment card to the police because there are police on the road who are checking people why were they traveling, and as a proof they had to show their treatment card. So they were reluctant to show their treatment card because there were instances when they were kind of reprimanded and looked down upon by the police. May not be arrested in that sense, but so those are the instances. But in which we have observed that that kind of fear that I have talked about could actually one of the potential factors for deterring people to take treatment, even if those are available to them. Thanks. Okay. Dr. Please.
I think that we won't take any more questions due to time constraints. And if anyone interested, they can interact with the presenter off-road. And both Dr. Abhishek and Dr. Swapnajeet, wonderful presentations. And in today's scenario, these are the hot topics. And any interaction will happen off-road. Thank you very much. Thanks a lot.
Thank you, sirs, for educating us on these very, very complex topics. I would now request our honorable chairpersons to kindly give away souvenirs to our speakers. May I please request Professor Ajit Avasthi, former head of department, to give away souvenirs to our chairpersons, please. I would also like to request our for yesterday's quiz masters to please come and take their souvenirs, please. Dr. Shinjini, Adgata, and Dr. Kshitij, sir. May I request Professor Basu, HOD department, to give the souvenirs to our yesterday's quiz masters, sir. Quiz masters, sir. Please come this side. Dr. Shinjini, please. Sir. Thank you very much, sir. We will now break for tea on the ground floor and we'll reassemble at 12 o'clock sharp. Thank you.